Bon dia, buenos dias, bonjour, good morning. Welcome to the second Mediterranean Health Forum during the Barcelona Media Week, the Mediterranean Week of Economic Leaders. I want to thank ASCAME to invite us to share health topics, to importance of health in economics and social life. We are living sensitive times due to the pandemic. Currently, economic crisis struggled healthcare, but now is the reverse situation. Healthcare problem struggled our society, economics, and politics. It's time to talk about healthcare. In this unique situation, the pandemic pushed our society to talk about health, about public health, about care, about health expenditure, about needs, about more beds, ICU, vaccines, doctors, nurses, professionals, telemedicine. Prime Minister are talking about health indicators, epidemiology, and people are discussing about vaccines, clinical tests, ICU performances, or vaccine logistics, taking a coffee. You know more than that. Society and governments are facing performance analysis of the health systems. What is good, what is necessary, what to reform, to implement, new tools, new needs, new organizations. How we can afford this with all moods, all organizations, all thinkings. These challenges are facing now us. Pandemic show to all us health problems have no borders, but have limits. And the limits is the existing organizations, poor prepared to afford pandemics, different capacities, no coordination through levels, communication problems within the professionals, the population, misinformation, problems about logistics, masks, ventilators, vaccines. That is doing a new industrial policy in many countries. COVID pandemics is having a major impact in all global health systems, and the Euro-Mediterranean region has no escape to this situation. The Mediterranean region has been seriously hit by COVID-19, and its health systems show all the inefficiencies, the insufficiently prepared to articulate an effective and coordinated response. After this intensive month of the emergency, health systems now beginning to recover, but with significant consequences. But the situations in the region are very different, very and significantly different. I will show you some data. And in this data, you can see the very different situations. I make a comparison between the health expenditure per capita, the percentage of the GDP utilized for health, infant mortality, maternal mortality, and the number of physicians and the beds. And the situation are extremely different between France, with the highest expenditure in the region, with 11% of GDP, through Burkina Faso or Chad with a very poor, and you can see extremely poor money for health. And with extremely poor financial situation for health, it's impossible not only to afford the pandemics, is to afford the health situations. Because the biggest problems and the most basic problems are on the table. Maternal mortality has differences of 300 times between Chad and Greece or Israel. And the number of physicians are one of the biggest problems in the south shore of the Mediterranean, with countries with no doctors at all, and a very poor situation in terms of number of beds. For that, sorry. And for that is necessary to to make different visions of this situation, because the countries has not the same capacities. This forum will address the situation created by the pandemic and the consequences for the health systems. All the countries are talking about serious reforms of the Mediterranean, in the Mediterranean region for health systems, what kind of infrastructures are needed, what is the public-private partnerships and how they can help to these developments, the role of the insurance companies and insurance industry, and a main thing is the new technologies in the health sector. Today, we will focus our panel in infrastructure needs and the role of digital health and innovation to solve that. And for that, we joined today a very extremely well-prepared panelist to discuss that. First, my friend Kautar Mbiati, Vice President Corporate Strategy and Development in Cytovia Therapeutics. She's consultant for different governments and with a deep knowledge of healthcare, from pharmacy to health politics through technology. Please, Kautar, we expect from you a general overview of the situation in the Mediterranean region, and with a special focus in the Africa. Please, Kautar, you have the floor. Thanks. I'm not hearing.
Can you hear me now? Yeah, apologies. I was muted. Thank you very much, Enric, for the nice introduction, and thank you to Askami for inviting me to this healthcare forum to share my vision on how we can build a digital healthcare ecosystem in low and middle income countries. My name is Kautar Mbiati. I am a medical doctor. I hold a master's in business, international policy and health economics from the London School of Economics, and I work as a VP for corporate strategy and development in a biotech. I am based in Boston, so it's a good morning for me, very early. This is my disclaimer. All the opinions that you will hear throughout the presentation are my own. Before digging into the topic, I think we all agree that the low middle income countries share a common set of challenges. You have the challenges that are related to public health and policy, just like Enrique has introduced you. There is a clear poor medical resources and a poor allocation of resources. There are problems of financing, coverage, big problem of inequality of access to care, let alone the other indexes that are very, very low. But today we are going to focus on the other challenges that are related to that could prevent the rollout of a successful digital healthcare ecosystem, or the implementation of a digital healthcare strategy within the low and middle income countries. And the fragmentation of the digital infrastructure is identified as a key barrier. This has a direct impact on the primary healthcare, which is inefficient. It has an impact on the level of preparedness to public health emergencies, and we know that there are others that are coming in the future. It leaves little room for innovation. When you have no digital infrastructure, there is difficulty to come up with new technologies. You can see the global international index for innovation in Africa, which is even lower than the average score of emerging markets. All these problems are fueled further by the brain drain, the number of physicians that are fleeing the countries, and the information technology engineers. So I would offer to present to you a first framework leveraging digital healthcare to predict and manage the future public health emergencies that are coming in the future. A second pathway, which is, I hope that you will find it interesting, which will roll out the pathway towards either a build-up ex nihilo of a digital healthcare ecosystem, or if there is already a foundation on how to improve this framework or this digital healthcare ecosystem in the low middle income countries. I would emphasize, just like Enric has said, the role of a multi-sector engagement in achieving this goal and in driving innovation and driving the economic growth in the countries. So you see in the map represented 8 countries from 8 emerging countries from Asia and Africa. And this is just to highlight the role of digital tools during the pandemic of COVID-19 in 2020. So in a country such as Vietnam, for example, there has been a suite of digital tools that were used to track and trace the individuals with COVID-19. In Rwanda, there was a huge uptake of telemedicine and the role of robotics in healthcare delivery with patients and carer support is undeniable. South Africa is a success story with that chatbot that has been initiated by a company named Turn.io. This chatbot has been translated into no less than 12 languages. It has been rolled out in several other emerging markets. It's had the label of the WHO, and in South Africa only, this chatbot has enabled around 11 million symptom checks across various industrial sectors. So a clear indirect effect on the economy in South Africa. So healthcare and economy are clearly intertwined. For future pandemics, I present to you these 2 frameworks. So these are telemedicine. These are telemedicine which are empowered by artificial intelligence. They will clearly solve the problem of scarcity of medical resources, and they would lift the geographic constraints. They will also balance the capabilities in the ICUs in case of a public health emergency. So how does it work? We can imagine a number of nodes distributed at the national level in a country, for example, and whenever there is an incoming call, this incoming call will be redirected to the node to where the medical capability is available and is most suitable. Another framework is we can imagine the capital of a country operating as a hub, as a center. So this is a centralized structure, and the capital would oversee the regions. I think this will be more adapted to low middle income countries and countries in Africa. The problem with these futuristic ideas is that in most low middle income countries, the digital primary healthcare landscape is fragmented. When you look at the number of connected participants within a network is clearly high versus when you compare it to China or to the United States. When to achieve a level of integration across several networks is just difficult. So you cannot have a connection, for example, between the patient, the doctor, the pharmacist, the payer, etc. So we need to move from this fragmentation and lack of interoperability. This word is very important. It will come over in my presentation. We need to move from this towards an increased rate of adoption within the target population. It can be the providers, the patient, the payers, or the private sector. We need to generate data that are usable that are interoperable and that are reusable for analytics, for machine learning, for business intelligence, for policy purposes, for research, for business. So this is where we need to go, and this has to be done very, very quickly and rapidly, meaning that the existing platforms need to be interoperable and interconnected with the newly formed platforms, at least at the national level. I'm not speaking about a Mediterranean network or a regional network as the one that is seen currently in Europe. But if we achieve it at the national level in each country, this is great, because it has a direct impact, as I mentioned, on the cost effectiveness of primary healthcare. It will drive better coordination in the healthcare delivery throughout the patient journey. And of course, it will translate into better clinical outcomes and higher quality of care. Definitely, this is the basis for innovation. There is no innovation without that. Of course, this comes with a certain number of challenges. Cybersecurity, data privacy is among these challenges. But blockchain can fix these issues. This is a decentralized structure when you compare it to cloud, and it can completely change the continuum of care. It can also change the tracking of prescription drugs, for example, throughout the supply chains. So very, very important, the interoperability. I promised to show you a second pathway on how to build digital healthcare ecosystem. There is no digital healthcare ecosystem and sustainable healthcare solutions or systems in the 21st century without a clear commitment from the leadership and the government, and without a digital platform readiness and the 5G. The contribution of private sector is critical. So we have a multi-sector engagement in order to implement the strategy that needs to be defined and rolled out. So these are the immediate, for me, the immediate priorities. When the number of participants to the network will increase, the level of integration of platforms will increase, then we can think about how to really optimize the policies, the legislation, and think of technology as a whole, as a long-term priority. So this pathway is very adaptable to the market archetypes, meaning that that some countries which have just beginning to build their ecosystem or their platforms, they can leapfrog one of the dimensions that I have shown. This table, as you can see, has a lot of colors, and the colors are not very homogeneous. The colors translate the level of country performance along 6 digital healthcare strategies or pillars for the implementation of digital healthcare strategies. You see most of the countries are in Africa, and apart from South Africa, where it's all blue, you can look at a country like Ghana, for example, and I will tell you why I am speaking about Ghana specifically, is because in Ghana, the level of mobile prescription is high, good performance. The penetration of internet is high, but there is no digital healthcare strategy national that is implemented. And most importantly, the skilled labor, the human capital to build and maintain the platforms is lacking. So this country can focus on building the human capital and designing a healthcare strategy to leverage the dimensions where it has a good performance. Whereas in countries where you have, sorry, you cannot see my title perhaps. So whereas in countries where there is a strong digital foundation and where the private sector is dynamic, then perhaps those countries can prioritize the interoperability. Remember, I told you to remember this word. They can prioritize the data exchange across 3 levels. So the micro level is the lowest level of interoperability of connection and data exchange. It happens only at the point of care. If we link this to the meso tier, so we link these data to the data of electronic medical record and operational systems and administrative system for claims or reimbursement, for example, with payers. And we link this towards another level, which is the macro level, where all the information will be shared across the continuum of care of a patient. Then we would have succeeded in building a sustainable and resilient and optimal digital healthcare ecosystem. The good news is that the Internet of Medical Things global market is booming, and it's supposed to be it's supposed to reach 52 billion in 2022, according to Deloitte.
Please, you need to finish because
yes, this is my last slide. This is my last slide.
Okay.
I would like just to emphasize the importance of public and private partnerships in increasing the global innovation index, which is lower than the average versus the emerging markets. I have chosen just the case of India to show how a strong government investment in interoperability and the strong private sector has driven the innovation and made the number of startups flourish, and the capital raised by these startups focusing on healthcare increase. So lack of operability is a barrier. We need to fix it. Interoperability will fix the primary healthcare model. It will enable the innovation. It will drive the economic growth. We need to do something about the brain drain. It costs in terms of GDP, and we need to build the capital, the human capital, in terms of big data analytics and so on. Thank you very much.
You're welcome. If it's after there is some questions, we can. And now we'll return to the concrete and the hardware, and in what kind of venues and what is the challenges for the systems to have. We need to build the same venues for healthcare than usually, or we need the pandemic show us new needs, etc. It's for that I ask 2 visions. First, Alberto Pineda, architect and founder of Pinearc Studio, is one of the most active companies in healthcare conception and hospital architecture, with experience in more than 20 countries, from Latin America to China, through Europe and in Spain. Please, Albert, the floor is for you. You have 10 minutes. 10 minutos. No lo oímos. We are not hearing Albert.
Yeah.
Ahora.
Sí. Muchas gracias por la.
Thank you very much for the invitation to this second forum, and especially thanks to Dr. Mayolas.
Aficiones comunes.
We have common interests. I'd like to talk as a Mediterranean architect. That is, I'll talk as an architect, or the way that in my studio we interpret Mediterranean architecture. We will also talk about the reflection that we have made in terms of architecture and how we have implemented them in our architectural projects. The most important thing of Mediterranean architectures are patios and cloisters. One essential element in the building of Mediterranean architecture, we see two examples here, the Alhambra in Granada or an Andalusian patio with an orangerie. So we have applied these kind of solutions to concrete projects of our own in order to make use of the weather and the quality of the environment that Mediterranean architecture has, especially in the field of health architecture. Here we see two examples of the Hospital del Mar. This is a hospital we've been working on for almost 25 years. Here we have a Mediterranean space, that is an internal and external space, a place to meet with other people. And this is something that you can only do in the Mediterranean because it's a soft weather with a strong light. We have to reflect about the way that we can filter this light. To the left, we let light through in order to avoid having a black space, so it lets light in, and to the right we have the entrance to a hospital. We should go to a hospital through a small door. We do it through a space of this kind. This is something that we have learned from the Alhambra in Granada and also in many other buildings existing in the Mediterranean. You do not enter through a wall, you enter through a promenade, which allows you to go through transitional spaces, spaces that make a transition between the inside and the outside. Another example of a patio, how do we conceive yachts? We do not do compact architecture, but rather we focus on yachts. This allows us to include vegetation, the light, and a certain relation with the outside. Another example here of a hospital in Spain, the idea of a cloister, of a yard, of these internal and external spaces at the same time. That is, they allow for people to stay here thanks to the climate, thanks to the sun and the light of the Mediterranean, which is essential for the architecture that we build in this part of the world. Now we are going to talk about biophilia. How do we integrate architecture in a context like this one, the context of nature? This is an example of a house at Coder, an important architect in the history of Spanish architecture. We see how it is integrated, at how the inside is closely linked to the outside. This is a research building that we built in Barcelona. We tried the sea to enter the building through this roof of the main hall, and also the combination between internal and external spaces. These are not closed hermetic spaces, but rather for many months in the year, researchers can work on these terraces. They can research or relate with other researchers in a different way, and not just as they usually do in a closed hermetic building. Another example of the Hospital del Mar. This is a room with a sea view. How do we design windows in the Mediterranean? We try to provide for faraway landscapes to include them, and also there's an importance for the relation between the inside and the outside, but always under protection. It also allows us to have a contact with nature, with vegetation, light, and external perspectives. We are also interested in the way that we use cloisters or semi-open or semi-closed spaces. In the hospitals that we've built, we've always tried to solve this issue. And one of the most important elements of Mediterranean architecture are shutters or blinds, which allow the air to get in and also to protect ourselves from the sun. This is something that we have applied here in the Hospital del Mar, following this idea of protecting from the sun, but at the same time, in order to maintain the contact with light, filtered light, and also protecting the privacy among different users. We also try to organize architecture in the context of the city in a different way. This is the Hospital of Vilanova i la Geltrú in Barcelona. We create spaces for transition, as we see to the right. The inside of the building is part of the public space, and then public buildings can be friendly to citizens. They do not become closed buildings, but rather open spaces where the external and the internal space mix. This is a building that we are finishing in Pordenone in Italy, really close to the sea. We have this element to protect from the sun, which allows us to create these spaces, these views, to have this relation between the interior and the exterior with a filtered light. Light is controlled in the Mediterranean. We cannot work with direct light in the Mediterranean. So after the pandemic, what do we think is going to happen? Of course, after the main pandemics or catastrophes that we've seen in hospitals, great ideas have been the result. In 1977, there was a building of the Hotel de Ville of Paris, and then an architectural competition was called. After that, there was a new design for hospitals, and after the Spanish flu, modern architecture was born, where white was used in hospitals, and also thinking that architecture could support the recovery process. What is going to happen now? Now we have digital patients, remote health assistants, robotics, automatization, and the medicine of the future, which will be predictive, preventive, personalized, and participative. This is going to change the design of hospitals completely. We will have to create more open hospitals following this Mediterranean tradition, where hospitals, we are going to go to the hospital much more frequently, not only to heal ourselves, we will go in order to do some preventive activities. Besides, in future hospitals, everything that can be automated will be automated. We automate already many systems like the kitchen systems and services, but many more things will be automated. We are already working with 5G technologies in Barcelona. 5G technologies has been done for remote surgery, 3D printing as well. So the hospital of the future will be an element with a high level of technological development. That's why we will have to build hospitals which are much more flexible. Therefore, we are working currently on hospitals with such dimensions, 750 per 750. I think we will have to work with larger metrics to include these new technologies. We have to contemplate the possibility of medicines to evolve, and for that we need different spaces. Also, air. After the pandemic, we will focus on air treatment in hospitals. It will be done with much more care than now. So we will have to increase the dimensions of hospital facilities in order to be able to move much more volumes of air to control and improve the ambience. Now we are working in order to have enough knowledge about the amount of air that we have in our buildings in order to control it and to be aware of the level that we have in terms of quality. Albert, you have just 1 minute before we finish. So the hospital of the future needs to be able to transform itself as an accordion. We need to be prepared. More pandemics will come. They will be completely different, but we need to have a building that allows for some flexibility. That's why we need large spaces, which came quite handy in this pandemic to host more sick people and to be able to cope with the difficulties at the time. Also, serial distributions. We cannot do labyrinths. We need an architecture that allows for sectorization and also all technologies to be included in our buildings. That's all. Thank you very much. Thank you, Albert. If there are questions, we will give them to you afterwards.
We are going to listen to your vision about your perspective of working in such a big company as Bouygues.
Hello, everyone. Indeed, we can ask ourselves quite a few questions on the needs of hospitals in the Mediterranean region, in the south of the Mediterranean in particular. So my concept today is that we are seeing a movement from the south to the north of the Mediterranean and to receive medical treatment in European hospitals, and this is absolutely something that must be avoided. And we especially, and as this has been mentioned earlier by Enrique, there is a deficit of physicians in a certain number of countries in the south of the Mediterranean. And the main challenge in the south of the Mediterranean is the lack of physicians. And so now the question is to avoid this physicians drain. What we note is that even if the number of physicians isn't that significant in these countries, when we don't provide the physician with or a nurse with tools, adequate tools, well, they don't tend to remain where in their countries of origin or places of origin where they were trained, and this is indeed problematic. And this is something that is also experienced in European countries. I mean, when there aren't adequate hospitals or tools and whatnot, well, obviously the physicians and nurses tend to leave, and so there are obviously some. This really contributes to the attractiveness of these facilities. So this is the first step and first effort. In parallel, it's important to continue to train medical teams in the south of the Mediterranean. By the north, there is a lot of exchange that occurs, and these exchanges need to continue within the Mediterranean. It's absolutely important. Now, another important point, and this is something that we've learned extensively in the past 10 to 15 years in Europe and in Western countries, is that it's important not to reproduce the mistakes or failures or mistakes that were made and over the past 30 to 40 years. Is that what we wanted is to create a word that was hospital-centric, that revolved around the hospital, with a lot of major, huge hospitals. For example, in France, we have twice as many hospitals compared with the population if we were to compare this with the rest of the countries, OECD countries, and in Europe. So we have too many hospitals, which makes their operating difficult, because we dilute the number of physicians and nurses in a large number of facilities. And even if we've never had as many physicians or nurses in France ever, but the actual number of physicians and nurses per hospital is low. So it's also important not to Europeanize countries in the south of the Mediterranean, because there are countries that need to develop their health infrastructure, such as the Maghreb countries, or other countries that need to actually develop from the outset, such as Libya, Syria, or even Lebanon, that is in a sort of intermediary situation. And so Catalonia, and this has shown, and the great example that was implemented for the past 20 years with a three-pronged health system. And so there are the health centers for long-term diseases and prevention treatment, which is absolutely essential. And so the local hospitals that also handle geriatrics, ambulatory treatments, and so small-scale urgencies. And then for for the rest of the specialties and all, it's important to have this three-pronged system. And so in France, there have been programs that have been launched, and so this is a solution that we need to explain to those that need to develop or reform their health systems. And so this makes it possible to better provide care to patients and to be closer to populations, and that has the lowest cost possible. So it's very effective. It's very easy to develop in a very short amount of time. So this being said, I mean, once we help the countries, so there are local hospitals and general hospitals. What is the specificity of these hospitals, these health infrastructures in the different countries? And in particular, for a constructor such as us, I mean, the opportunities that this can represent, and so these difficulties can, in fact, represent the obstacles. And so the first obstacle is especially these health infrastructures that need to be developed, and that we can also focus on the strategic challenges of the creation of a health infrastructure and a health system. We have many countries today that have a hard time getting on the right track, and that aren't really supported to create a health system. and that aren't very much support, that aren't, or that receive the support from consulting firms or strategic consultants or whatnot. And so sometimes these projects are launched and then come to a halt and have a hard time receiving financing. What we noticed in the countries in the Maghreb, which where there are health professionals. I mean, there are health professionals, but unfortunately, they do suffer from this physician's drain. And so generally, these health expenditures are at 8% in 8% per capita in Algeria, 5% in Morocco, whereas it should be at least 12% of GDP per capita. And so it's unfortunately there are enough, as I mentioned, enough allocated resources. So there's also these health infrastructures. I mean, we need to see whether there are real differences between what we see in the countries in the north of Europe, in Spain, France, Germany, the UK, and Europe. And so there isn't really any significant difference. So Albert spoke extensively about the architecture, so we can see that we can have there are interesting architectures that are implemented in the north and south of the Mediterranean. There are also a certain number of specificities recalled by Albert, which is having the buildings that are more open to the outside areas, to address these services from outside, as we would do so in airports, for example. But now, whether this is in a specificity of warm countries per se, or this is something that's done in the US or Canada, that are colder countries for the most part of the year at least. And so for most of construction-wise, there isn't much difference between countries in the south of the Mediterranean and in Europe, whether it is in terms of a structure or the materials used, etc. So maybe, for example, for the flooring, there's might be different materials that you use. The major difference is especially the HVAC, the heating, ventilation, and cooling systems. And it's also important to recall that the countries in the south of the Mediterranean, the Middle East, and the Maghreb had a very big culture, a major culture of bioclimatic cooling of the buildings that should also be updated. There's also reused. For example, in Northern Europe, there are some cooling or heating or cooling systems that use watersheds. And so for example, reinventing in the south of the Mediterranean what was done in the past to redeploy in the south of Europe, for example, to have smart cooling systems, it should be considered. And so this is done in remote areas, for example, and with cooling using seawater or cooling using wind energy. And so these are all technical subjects that should be considered. And so these are technical topics that can really make the difference in the design of healthcare systems in the countries in the south of the Mediterranean. Now, as far as the local hospitals, there are some areas, and I will just show you a few images. So I will go ahead and share a few images with you. We've built some hospitals in the south of the Mediterranean, which are, for example, one that's near Casablanca, which meets meets the standards of university hospitals. One part of Morocco with traditional constructions, but however with outdoor spaces that are extremely pleasant. There's also a building of a university hospital in Benin, where we see a very much open building with different outdoor spaces with efficient solar protection. And there's also the development of concept or creating of modular hospitals for a certain number of countries in the south of the Mediterranean, where today there's a will to where there's a will to deploy these types of hospitals in a great part of Africa. And so the idea is to standardize the building to avoid having to reinvent plans and every single time. And so the benefit is to be able to avoid design errors and to gain a lot of time and to have, for example, community hospitals and that are ready and operational in a very short amount of time. And so for the community centers that are the third pillar here, I don't think there's really anything to add or anything to reinvent it. We simply need to build on the capacity to construct traditional housing in these different countries. And so by having units that could today be sort of pretty much standardized and, for example, for housing up until ORs, with these industrial models, things can really take a faster pace and very quickly meet the needs of countries, particularly in the south of the Mediterranean, for the deployment of their various systems. So we can see here that in France, following the COVID crisis, there is a huge momentum, investment momentum that has been launched in the UK, has been done in a few years ago in many European countries. We continue to build, and we do continue to build new health infrastructures and health facilities. And this is to better meet the needs of patients and of the populations, whether it is in terms of long-term care up until the treatment of complex diseases in highly technical hospitals. Not to mention the whole technological evolutions of medicine in general and connected hospitals. But all of these experiences that we've acquired can be deployed and can support the countries in the south of the Mediterranean, especially. We need to understand what projects are to be launched and the development strategies of these health infrastructures. And so these health infrastructures need to be three-pronged, and the appropriate financing must be allocated in order to be able to do this in a short amount of time. And I think that the north of the Mediterranean is capable of rapidly and smartly supporting the southern countries of the Mediterranean to ensure the success of such a plan and program. Thank you.
I move again to the technologies. Thanks, Claude. S'il y a des questions, on va le mettre à la fin.
If there are any questions, we'll leave them for the end of the session if we have time.
After the nice introduction of Kautar, to most concrete examples on technological developments, I want to introduce Sergio Iraizoz, Business Development Director from Medictor. It's a Catalan company based in Barcelona. We'll talk about artificial intelligence and technologies. Please, Sergio.
Muchas gracias, Enric.
Thank you, Rick.
Show my screen. You should be seeing it.
Yeah. Alors, vous devriez la voir. OK, très bien. Donc, comme il a été dit, j'aimerais vous présenter mon point de vue aujourd'hui. Et d'ailleurs, merci beaucoup de participer à ce forum. Merci de participer à cet événement. J'aimerais commencer en vous montrant ce que nous faisons, en vous montrant des exemples concrets. Pour nous, ici à Medictor, nous avons compris certains des enjeux mondiaux lorsqu'il s'agit des besoins en soins de santé. L'accès aux soins de santé est un problème encore non résolu dans le monde. Évidemment, selon les pays, la situation est différente, mais le problème est bien mondial. Donc, l'un des problèmes que l'on voit, c'est l'accès à la santé qui est inefficace et les informations que l'on a entendues au début de la séance nous ont montré qu'il y a vraiment un manque d'accès général pour tout le monde aux soins de santé et ça prouve l'inefficacité du système, surtout en ce qui concerne les soins de santé primaires. Dans certains endroits, cela peut être dû à une demande excessive, mais parfois, dans d'autres situations, c'est parce qu'il y a vraiment une offre insuffisante. Et ceci peut avoir un impact plus fort sur les pays.
It's in that context, whenever it is that we are facing the need to solve those challenges, that artificial intelligence and topics like telemedicine or any tool that may provide some value with regards to solving those challenges and bringing efficiency to the system do have a role. Those tools do have a role to play in that situation. In our case, when we're speaking about Medictor, what we are developing is what we like to call the most accurate virtual medical assistant for triage and pre-diagnosis. With that, what we mean is that we can provide a simple tool for everybody to use simply with a mobile phone or eventually through a web browser, so with a more regular computer. It's a solution that will enable anybody to get right away and in a simple manner information about what we might define like the triage level, meaning the level of emergency that someone might be having based on the symptoms and condition that someone might be experiencing, together with an initial pre-diagnosis, what we might call a differential diagnosis, that it's indicating what might be wrong with that person. Okay, that's the aim. I mean, that's what we are trying to do. And thinking back about how the pandemic has changed all of this, what I can share is that significant part of last year, primarily when the pandemic, when we had the outbreak of COVID, we experienced an exponential growth in the evaluations that we were seeing through our system. At some point in time, it was even multiplied by 10. And this only proves the fact that the pandemic has changed things. Probably it was like in the technological domain, probably it was like a tsunami of changes that brought along changes that otherwise would have happened in the course of a couple decades, maybe. But it all sped up, right? I mean, hence that exponential growth. If that's not maybe there to stay, because most probably we will get back to something in between what we used to have and what happened during the pandemic, it's a still reasonable to think that applications like the one I'm talking about today and eventually others that will leverage artificial intelligence, telemedicine, and other technologies in the end will have a role to play within the healthcare of the future. And particularly if we're thinking about, once again, low and medium income countries and thinking about the situation that we have with countries in the southern part of the Mediterranean, where, as we will discuss and as I will mention, that efficiency is also needed. Obviously, in that case, we know that we have scarcing resources, so limited number of hospitals, no physicians, no nurses. So in that sense, we need tools that really work towards providing value, healthcare value to the people with a limited cost, and that can work in that context, right? In a context in which those key resources will be scarcing. So back to the solution as such, and just to tell you a bit about it and how that might be, how it could be useful in the context that we're discussing. To be mentioned that Medictor, it's as I said before, it's a simple solution to use, right? I mean, you can once again download an app on your cell phone, and through that application, you can start speaking to the solution the same way that you would be speaking to a physician, and the system will guide you through an evaluation until it gets a result for you in terms of the triage level, so how urgent your condition might be, and which could be the diseases that you could be suffering. But that's not good enough, right? I mean, at the end of the day, we're thinking about something that needs to be reliable. So in that sense, what Medictor is adding, it's the fact of this massive clinical database that has been accumulating clinical data for almost 10 years, for a bit more than 10 years now. Medictor, it's a 10 years old company as we speak. And as we speak as well, we can diagnose a bit more than 850 diseases. And then there are thousands of questions, symptoms that come into play within the artificial intelligence engine to always come to the best possible result, okay? Also to be considered, and this is something that it's needed when we're thinking about a approach that could be leveraging resources or helping scarce resources here and there in different countries, it's that the solution needs to be global. So in that sense, Medictor, for instance, it's an already translated solutions up to 15 languages as we speak, and that it's needed because that easiness of use needs to be applied not only to the process that we deploy, but also needs to take into account the differences that we have in different countries, right? Not only from a linguistic perspective, but also from the point of view of how things are expressed in that specific language, right? Terms on how we refer to conditions, for instance, and taking into account through the NLP capabilities of the solution. Something else relates to the technology, which is fully open. So in that sense, can be used in different contexts like web, like app, meaning mobile, eventually even through voice assistants. And also considering that this needs to be integrated. We were saying before we were discussing before about how this escalates through the EMRs, for instance, and the different layers, just to ensure that the information is shareable. And that's the case. I mean, when you have solutions that can be integrated, that's way easier to have happening, right? The fact that not only the patient it's inputting that data, but there is indeed a data flow that really enables that information to be collected by any actor within the healthcare process. A couple more things to mention: the fact that Medictor is experience already in working with different domains, and I just wanted to show this because I think that once again, when thinking about countries that have difficulties today, that are struggling, but at the same time that may have the chance to really develop something from scratch, which is different from what we have today, meaning that they can immediately leverage digital technologies in places where there is internet penetration or mobile utilization and so forth. It's an opportunity, right? But that opportunity eventually will require the support of some partners. And I can tell you, as we speak, we are working with some of these companies in really trying to approach the needs of these less fortunate countries, we might say, that may not have full resources to cope with this type of technologies, but that we are all together making that effort so as to try to make this happen for them as well. One more thing is related to the fact that we're speaking about a validated solution. So it's not some fancy solution that tells you that provides you with some clinical data. Any information we're providing, it's clinically validated. And let me just jump into this one, because once again, I mean, as I was probably let me close on this for being cautious of time here. The fact that, as said, right, I mean, there is an opportunity that we are seeing if we're thinking about what Medictor could be doing, simply because we are present in a significant number of countries as we speak. We have partners with us supporting all steps in all steps that we are taking, and we believe, and I personally believe, that experience that we have, it's one experience that could be useful for these countries, in which, as I said, we are already starting to develop some experiences with the target of, once again, and let me close by saying that once again, to truly try to build together with them the most efficient access to healthcare, in terms of saying we will not be able to, in some cases, eventually build completely from scratch a full healthcare system the way that we understand a healthcare system needs to work based on our experiences in Western countries, for instance. So in that sense, reimagining all that healthcare system for them, leveraging digital technologies, leveraging artificial intelligence, which, by the way, doesn't mean that needs to replace physicians, right? But understanding that there will be a lack of physicians, a lack of nurses in the years to come, a lack of professionals, which is a reality in some of the Mediterranean countries, as we saw before. We need to cope with that. We need to understand that that's a reality. So we need to try to provide as many tools as possible that can really help in creating something different, but that still will provide will try to cover the healthcare needs that people in all these countries will be having. I think that would be it. More than happy to take it further and solve any questions or doubts that you might have.
Thanks, Sergio, for your accuracy on time and clear presentation. And go to the next example of a concrete experience. Let me introduce Amir Bozorgzadeh, now based in Lisbon, about an example of use of virtual reality. Amir, you have the floor.
Thank you very much, and thank you for having me today. My name, as I've been mentioned, is Amir Bozorgzadeh. I'm the CEO and co-founder of Virtuleap. We are a company that combines neurosciences with virtual reality and other emerging technologies in order to address the huge impact that cognitive disorders have on society, of course, globally. There's about estimated 419 million people around the world who suffer from anything relating to learning challenges like ADHD, autism, concussion therapies, and the like relate to conditions that are contingent even on even increasingly we've seen neurological disorders associated to COVID. But more importantly, I think the gravitational pull is always towards cognitive decline, and specifically Alzheimer's disease, which costed last year alone $1 trillion. And the amount of devastation on the quality of life of the individuals as well as the global economy dwarfs everything else in this sector. I think when we look at countries like Japan and Asia in general, but Japan is a very special case, cognitive disorders are really treated in a much more proactive way than anywhere else in the world. I think that's partly because of the demographic split in Japan is already in a place where the older adults outnumber children for the very first time in history for quite some time. In the US, for example, that won't happen, that demographic change, until 2030. In Europe, depending on the country we look at, we are already at that demographic split, and we can start to see regulatory bodies and healthcare practitioners and society at large start to look at mental health and mental fitness in a more proactive way, but we have a long way to go. In terms of a lot of these cognitive disorders, they might not have any solutions, like in the case of Alzheimer's. There might be some exceptions recently, but by and large, it's still a very, very scary disorder that we can only really retroactively kind of address once we have it. This is kind of at odds with the fact that if we were to be able to go as individual end users and access the fMRI machines at hospitals and get neuroimaging and brain scans, we would be able to potentially detect a cognitive disorder or a trend towards a cognitive disorder up to 25 years before its clinical onset. The problem is these kind of solutions, these biometrics or biomarkers are highly invasive. In places like the US, it can cost upwards of $7,000 to get a single screening to be done. Of course, in Europe, it's much more easily facilitated, but it's also, there's a taboo to going and getting these kinds of scans and these kinds of screenings. Most of us would rather not go about and find out anything like this if we don't have to. And that is the problem. We have missed a very big window of time in many cases before we start to have subjective cognitive deterioration, when we notice it in ourselves and we kind of just don't take it seriously. And so the call to action amongst startups like Virtuleap is to create more less invasive, more accessible solutions that can be able to, even at the very least, serve as a proxy to those types of biomarkers. Can we correlate our solutions of cognitive assessment, for example, to at least prompt someone to be able to more earlier go and see a neurologist, for example. Now, the problem or the challenge is that most of these cognitive assessment solutions are screen-based, which means they exclude the body. And modern neuroscience invariably always says that cognition is inherently embodied. And virtual reality comes in right here because it is the first digital format that is inherently embodied, that engages the body. In fact, it bewitches the body. If I were to be in a VR simulation standing on top of a very tall tower and I have any sense of a phobia of heights, my knees will buckle and shake. It doesn't matter if I know I'm in my living room. The autonomic nervous system, the vestibular balance system, our proprioception believes that this virtual reality simulation is real. As of last year, or actually it's more poignant to say this week, in fact, the FDA declared the first VR solution for pain management now marketable. Last year they created a new category dedicated to VR called medical extended reality. Why do they do this? Because, for example, in the pain management solution example, when your visual sense is tricked into believing that this embodied spatial reality is real, the pain receptors in the brain for some reason dampen. Now, there's a lot of research being done. In fact, there's been over 8,000 studies to show how the healthcare application serves as a critical use case for VR. Now, in the case of cognitive assessment, the data quality is that much more higher quality in terms of the engagement that is unprecedented because the non-verbal circuitry of the human condition believes this experience is real. But also we're talking about volumetric data sets being captured by these headsets. Now, in 3 minutes, in fact, of our games, for example, and our content, we collect over 200,000 data points, which includes not just the game moments and the environmental interaction moments, but also the positioning data, the postural data. And more importantly, as of this year, devices even have integrated physiological sensors like pupil dilation tracking, heart rate variability, skin conductivity, face tracking, haptics that can even allow the sense of touch for use cases like rehabilitation. This is a tremendous amount of data, an order of magnitude more data, if not 2 orders of magnitude more data about the human condition being collected. And what can we do with that data? Well, ultimately, from a HIPAA compliant sort of very sensitive way of leveraging it with best practices and for the most beneficial applications for society at large, we can be able to apply AI learning tools and create digital phenotypes or digital health biomarkers, which is fairly, I would say, the holy grail of where this technology is leading us to. And so virtually specifically, what we have done is we've created a library of VR games designed by our neuroscientists as translations of very standardized neuropsychological assessment tools that have been around for decades, or creating games inspired by the latest of neuropsychological principles to essentially test and train specific cognitive domains like memory, information processing, problem solving, but also because of virtual reality, we also have motor control, spatial orientation, spatial audio awareness. We've created 14 of these environments to date, and specifically they go beyond just those main 7 categories that I kind of loop into this slide. They actually go into 20 plus categories that we target, like memory breaks down into working memory, short-term memory, long-term memory. And you can kind of see the nuance and the subtlety and the elaborateness of this data and how niche it is and how it could be applied in so many creative ways to allow individuals on the one hand to serve as an assessment tool, the new gold standard of diagnostics potentially, something that can readily be available to a user that they can consider it like the gym for the mind and be able to do a little cognitive workout every day and keep track of how their lifestyle might be affecting their cognitive performance. We've seen in our own data that if you sleep less than 6 hours as a user, you can see that certain cognitive categories do decline in our deficit compared to other ones. Like if I sleep less than 6 hours, attention scores noticeably go lower, certain types of short-term memory skills go lower, spatial orientation and motor control, funny enough, we have not seen to go lower, but attention and awareness and understanding, this is the new generation that is befolding, I think, what we are calling, at least in our world, the empowered patient, and being able to take data through our Fitbits and our smartwatches and integrate to these data and make everything more and more readily available, not only to the end user, but also have enterprise platforms that can ultimately allow healthcare practitioners. We're working with the VA healthcare system in San Francisco. We're working with Penumbra for stroke rehabilitation. They allow it to be part of their systems where they can have access to administrative panels, reporting, user management, but also integrate to their health system, integrate to their other types of tools. We've created two telehealth companion applications, for example, one that allows you as a practitioner to remote navigate the virtual reality experience using your tablet or your phone without the person having to remove their headset or be in the same country, as long as you have Wi-Fi internet connection, to be able to introduce, for example, a survey before and after the session and make it more productive for the point of view of some of the studies that we're actually currently doing. We have one study in Barcelona right now with Valdebrun, 18-month study focused on whether we can slow down cognitive deterioration in type 2 diabetes sufferers, because that is a high risk factor towards developing Alzheimer's disease. In the US, we're partnered in a consortium where we want to apply our solution to see if it can improve the quality of life of those suffering from MCI or Alzheimer's disease. So these kind of tools, these back-end systems and enterprise kind of features are really—
Amir, one minute, please.
Oh yeah, I'm watching as well. So ultimately, you know, we want to be able to use our technology to go above and beyond the two kind of rows here of standard solutions that have been around for quite some time, but have never really evolved from pen and paper or digitized versions of pen and paper. The body needs to be engaged. And unfortunately, we're very lonely in this sector because it is the Wild West of emerging technologies, trying to make things readily available, not only to our cognition, but to the whole body, and have a holistic approach to these types of healthcare solutions. But I'm out of time, and I really thank you for all being able to be here to let me share with you our technology and solution.
Thanks, Amir. And now to close our panel, I invite Maria Huiscam. He's Chief Communication Officer of Barcelona Health Hub, to explain this initiative of platform to encourage innovation in healthcare. Maria, you have the floor.
Thank you. Thank you, Enrique. Thank you so much for having me today. Thank you also for trying to pronounce my name. I know it's not not easy. I'm Maria Huiskamp. I'm Chief Communication Officer at Barcelona Health Hub. And I'm here today to tell you a little bit about what we do and what Barcelona Health Hub tries to, how we try to promote innovation in digital health. As you can see, the big building over there, that's actually our headquarters. So it's not the worst place to work in. Barcelona Health Hub, we are a private non-profit organization, and our main goal is to promote innovation in digital health. Well, how do we do that? We do that through generation innovation in health through IT. We also promote startups of the health environment in order for them to reach the public. Oh, I'm sorry, other slide. Sorry. Sorry, to reach the public in private healthcare. And the last thing is to foster interactions between all those digital actors in digital health. It's very important. I will tell you a little bit later about that in more detail. First of all, we're located in Barcelona. As you can see on the map, those purple spots with a B, that's us. That's our headquarters. We're based in the Sant Pau Army Road site in Barcelona, which was actually a former hospital for 100 years. The other colored buildings you see, they're also within the complex. It contains a university, a hospital, and some foundations with whom we work together very closely. Well, then Barcelona Health Hub. You can see us as an umbrella organization where we try to combine all actors working in digital health. As you can see, at the moment we have 300 members, which like 2/3 of them are mainly startups in all shapes and sizes and stages that you can imagine. The other part of our members are like anybody else. So big corporates like pharmas and insurances, but also universities, hospitals, clinical research, and we also have some investors and venture builders within our system. Basically, we are trying to unite the whole digital health ecosystem. And where do they work in? Well, about anything. As you already heard from the other speakers today, the digital health options range from prevention to artificial intelligence to elderly care and clinical trials. It doesn't really matter where you work in. You're always welcome at BHH as in our ecosystem. The thing is, Barcelona Health Hub, we don't innovate ourselves. The innovation comes from our members. As Enrique already told us at the beginning of the panel, healthcare has no borders. So for Barcelona Health Hub, it doesn't really matter where you are located. Although we are located in Barcelona in Spain, it doesn't really matter if your company with your great solutions, with your great ideas and innovation, if you are located in Spain, in Italy, it doesn't matter. We have actually members from all 5 continents. So ranging from Nigeria to Indonesia to the United States, everybody's welcome because we think that together as a digital health ecosystem, we can promote innovation in digital health. In the last year, well, since the start of the crisis of COVID, we have seen as BHH a jolt into the process of innovation. Like I said, we don't innovate ourselves, but we, of course, we encourage everybody to share their solutions. The pandemic, as we've seen it, has caused a great push in e-health, and therefore BHH has been growing a lot, especially since the beginning of this year of 2021. We see a great push, a great interest from all kinds of companies working in digital health to work together towards promotion in innovate more. How do we do that? For example, with international events. Once again, it doesn't matter where you're located. Digital health is everywhere. Our big annual event is the BHH Summit. We actually had a BHH Summit a few weeks ago about the patient journey. Today, everything is hybrid because, of course, we want to provide our service to everybody around the world. But maybe interesting to mention is that in April, we organized, for example, the BHH Summit Ibero-America. It was a Spanish-speaking event directed to the Latin American market, because the whole point of that event was to strengthen the ties between the digital health ecosystems between Latin America and Spanish-speaking Europe. It was actually quite a good success, and we hope to repeat that kind of events, like connecting specific ecosystems throughout the world. We hope to repeat that more often. What is our big goal? The big goal is what we want to achieve is to Barcelona Health Hub to become the largest digital health hub in Europe. The ambition is there, and now we are working on the execution of it. The project has a total investment involved of 22 million euros. And what are we going to do with that money? Well, that's the next slide. It's those 4 points are the key pillars of our next generation project. The first one is we want to develop a digital health technology transfer center where we want to connect the hospitals within the ecosystem. Secondly, we would like to become a reference center for the generation, distribution, and exchange of knowledge in digital health. And thirdly, we would like to expand the incubator to promote startups. At the moment, we have many startups already working with us in that great complex I showed you before. And we would like to renovate one of those old ancient buildings to put the startup incubator over there as well. And last but not least, it's a quite ambitious program, but we are going for global expansion. It's basically connecting and expanding our hub's presence in other areas to help broaden the digital health ecosystem. And I know we're called Barcelona Health Hub, but our ambition is bigger than that. The ones you see over here, I already mentioned, at the moment we have 300 members and we're growing pretty fast. This is just a small overview from the members that we have at the moment. As you can see here, Medictor where Sergio just talked about, he's actually a member of the BHH ecosystem as well. So he's proudly present in the same building as we are. And this is just a small overview. Short but sweet, I would like to thank you all. If you have any questions about what we do or how we can work together, of course, I would invite you all to contact us. Happy to help, happy to answer some questions. And that's about it.
Okay, thanks, Marja. It's almost a miracle. We finish on time. It's time, different timetables of the people now. There's no questions at the moment. I think we can keep in touch through mails. And I want to thank everyone for your presence, for your contributions. And we work, that is clear, health has no borders, and we explore more on the limits. Thank to all of you and have a nice day. Next time in Barcelona. Thank you.
Thank you. Bye-bye. Have a nice day. Thank you.
Bye.
Bye-bye. Bye-bye.